Hello students, I am Dr. Indhumathi, Senior Lecturer from the Department of Oral Medicine and Radiology. Today we are going to discuss about fungal infections of oral cavity. Mycology is the study of fungal infections and it has gained a remarkable impetus in the past few decades due to the fact that the fungal diseases are far more common than was previously suspected. Most of the fungal species encountered by human beings are saprophytes. Saprophyte is an organism, often a fungus or bacteria, that obtains its nutrition from dead or decaying organic matter. But on occasion, these saprophytes can cause infections in human beings. Disease caused by fungus is known as mycosis. Predisposing factors for most of the fungal infections include metabolic disorders such as diabetes mellitus, toxic states such as chronic alcoholism, and immunodeficiency and immunosuppression. Local factors such as tissue damage with suppuration and disturbance in the normal bacterial flora also predisposes in susceptible individuals. Endemic mycoses such as blastomycosis, coccidiomycosis, and paracoccidiomycosis are recognized as health risks among travelers who visit or reside in an endemic area for a short period of time, and they often acquire such diseases. The risk of acquiring such an endemic mycotic infection is particularly higher among immunocompromised individuals. The diagnosis of oral fungal infections is mainly based on clinical presentation, cytology, and histopathology of the lesional tissue. The methods to detect the fungal organisms have also evolved from culture to rapid molecular tests like polymerase chain reaction, which is your PCR. A PCR test for fungal infections is often referred to as pan-fungal PCR test, and the reports of this pan-fungal PCR test will be available within few hours. This is significantly quicker than the 3 to 7 day turnaround time for standard fungal cultures. Prompt evaluation of oral lesions is essential to establish the diagnosis, initiate therapy, and monitor clinical progress. Let us look into the clinical groupings for fungal infections. Mycosis is of 5 types. They are superficial mycosis, cutaneous mycosis, subcutaneous mycosis, systemic mycosis, and opportunistic mycosis. Superficial mycosis is limited to the outermost layer of the skin and hair. Examples include tinea nigra, pityriasis versicolor. Cutaneous mycosis extends deeper into the epidermis as well as invades hair and the nails. Examples include microsporum, trichophyton, and epidermophyton. Subcutaneous mycosis involves the dermis, subcutaneous tissue, muscle, and fascia. Examples include sporotrichosis, mycetoma, and chromoblastomycosis. Systemic mycosis originates primarily in the lungs and may spread to many organ systems. Examples include histoplasmosis, blastomycosis, and cryptococcosis. Opportunistic mycosis. Infections of patients with immunodeficiencies who would otherwise not be infected. These infections include candidiasis, aspergillosis, as well as mucormycosis. These are some of the oral mucosal fungal infections. Candidiasis is the most common oral fungal infection, which is caused by Candida albicans in most of the cases, and also by Candida glabrata, tropicalis, dubliensis, and cruizi. Aspergillosis is caused by Aspergillus fumigatus. Blastomycosis is caused by Blastomyces dermatidis. Cryptococcosis is caused by Cryptococcus neoformans, and causative organism for coccidiomycosis is Coccidioides immitis. Geotrichosis is caused by Geotrichum candidum. Histoplasmosis is caused by Histoplasma capsulatum, and mucormycosis is caused by the fungus Mucorales, and paracoccidiomycosis is caused by Paracoccidioides brasiliensis. Penicilliosis is caused by Penicillium magnifi, and sporotrichosis is caused by sporothric fungi. Candidiasis is the most common mucosal fungal infection. It is also called as candidosis, moniliasis, or as oral thrush. Candidiasis is a true opportunistic infection and causes oral infection when there is an underlying predisposing condition in the host, such as immunosuppressive state. And the normal mucosa harbors candida, and the infection becomes predominant only when there is alteration in the normal flora, and also when there is a immunosuppressive state and altered metabolic state such as diabetes mellitus. The primary form of this disease is very rare. Skin, mucous membrane, nails, and internal organs are commonly affected. Because of the genus name Monilia, the disease is called as moniliasis. The other names are thrush, candidosis, or Lee Muget, which means lily of the valley. Candida albicans is the most frequently associated species with normal oral carriage in humans, occurring in the mouth of up to 80% of the healthy individuals. Candidiasis is mainly caused by yeast-like fungus Candida albicans, but other species such as Candida tropicalis, Candida parapsilosis, Candida stellotida, Candida krusei, Candida Euler-Monti, Candida dupliensis, Candida rugosa, and Candida vishwanti and Candida glabrata. A fungi can occur in three forms. The first form is yeast form, which is not an infective form, and Candida albicans is present in the normal oral mucosa in yeast form. The second form is pseudohyphae. The pseudohyphae form is presented as elongated arrangement of the yeast form. And the third one is chlamydospore. Chlamydospores are nothing but they are bulb-like structures attached at the end of the pseudohyphae or in the middle of the pseudohyphae, and they are the asexual spores. This is the structure of Candida albicans, which has both the pseudohyphal form and chlamydospore forms. The pseudohyphae and chlamydospore forms are more infective than the yeast form. In general, Candida species differ from one another but can be identified by the formation of pseudohyphae or by biochemical tests. Candida, common inhabitant of the oral cavity, gastrointestinal tract and vagina of clinically normal persons. Under favorable conditions, the organism transforms into pathogenic form, that is from the yeast form to hyphae form. Oral candidiasis. Oral candidiasis is the most prevalent opportunistic infection affecting the oral mucosa. In the vast majority of cases, the lesions are caused by Candida albicans. Candida albicans is a weak pathogen, and candidiasis is said to affect the very young, very old, and the very sick, because in both the very young category and the very old population, immunity is compromised. Immunity is not developed in the very young population, and immunity is compromised in most of the elder population. Also, it affects very dry areas, such as in case of xerostomia, candidal infection is more prevalent. Most candidal infections only affect the mucosal linings. Oral candidiasis is divided into primary and secondary infections. The primary infections are restricted to the oral and perioral sites, whereas secondary infections are accompanied by systemic mucocutaneous manifestations. Classification of oral candidiasis. It is classified into primary oral candidiasis and secondary oral candidiasis. Primary oral candidiasis is again classified into acute, chronic, and candida associated lesions. Acute primary oral candidiasis comprises pseudomembranous candidiasis and erythematous candidiasis. Chronic primary oral candidiasis comprises pseudomembranous candidiasis, erythematous candidiasis, and plaque-like candidiasis, nodular candidiasis. Candida-associated lesions are denture stomatitis, angular cheilitis, and median rhomboid glossitis. Coming to the secondary oral candidiasis, familial chronic mucocutaneous candidiasis, diffuse chronic mucocutaneous candidiasis, candidiasis endocrinopathy syndrome, familial mucocutaneous candidiasis, severe combined immunodeficiency, DiGeorge syndrome, chronic granulomatous disease, acquired immune deficiency syndrome. These are all the conditions which are associated with candidal infection. So they are called as secondary oral candidiasis. Etiology and pathogenesis. Candida albicans, Candida tropicalis, and Candida glabrata. These three species comprise together over 80% of the species isolated from the human candidal infections. To invade the mucosal lining, the microorganisms must adhere to the epithelial surface first. Therefore, candidal strains with better adhesion potential are more virulent than strains with poorer adhesion ability. We had already discussed that yeast forms are less infective compared to the pseudohyphal form and chlamydospore forms. The yeast's penetration of the epithelial cells is facilitated by their production of lipases. So these lipases are the enzymes which are produced by the fungi, and this helps in the attachment of fungi to the oral mucous membrane. An association has been found between oral candidiasis and the local and general predisposing factors influencing it. Pseudomembranous candidiasis is also associated with fungal infections in young children who neither have a fully developed immune system nor a fully developed oral microflora. Denture stomatitis, angular cheilitis, and median rhomboid glossitis are referred to as candida-associated infections, as bacteria may also cause these infections. There are local and general predisposing factors for oral candidiasis and candida-associated lesions. Local factors include denser wearing, smoking, atopic constitution, which is your genetic constitution, inhalational steroids, topical steroids, hyperkeratosis, imbalance of the oral microflora, quality and quantity of saliva. General factors include immunosuppressive diseases, impaired health status, immunosuppressive drugs, chemotherapy, endocrine disorders, hematinic deficiencies. Epidemiology. The prevalence of candidal strains as part of the commensal oral flora shows large geographic variations, but an average figure of 35% has been calculated from several studies. Candidal strains are more frequently isolated from women. A seasonal variation has been observed with an increase during summer months. Hospitalized patients have a higher prevalence of yeast. In healthy individuals, blood group O and non-secretion of blood group antigens are separate and cumulative risk factors for oral carriage of Candida albicans. In complete denture wearers, the prevalence of denture stomatitis has been reported variously from 11% to 67%. Clinical findings of pseudomembranous candidiasis. The infection predominantly affects patients taking antibiotics, immunosuppressant drugs, or having a disease that suppresses the immune system. In patients, those who are taking antibiotics and immunosuppressant drugs, the normal oral microflora gets altered, and this gives the space for Candida species to overgrow and results in candidiasis. The clinical presentation of acute and chronic pseudomembranous candidiasis are indistinguishable. The chronic form may emerge as a result of human immunodeficiency virus infections, as patients with this disease may be affected by a pseudomembranous candidal infection for a long period of time. Patients treated with steroid inhalers, such as those who are asthmatics, may also show pseudomembranous lesions of chronic nature. This is a case of pseudomembranous candidiasis during the immunosuppressive phase following heart transplantation. Erythematous candidiasis. The erythematous form of candidiasis was previously referred to as atrophic oral candidiasis. The erythematous candidiasis has a diffuse border. Here we can see erythematous candidiasis caused by inhalational steroids. The palatal erythematous candidiasis lesion has a diffuse border. This could help us to differentiate it from erythroplakia. In erythroplakia, there will be sharper demarcation and often this appears as a slightly submerged lesion, whereas erythematous candidiasis appears as a diffuse erythematous lesion. Erythematous candidiasis may be considered a successor to pseudomembranous candidiasis but may also emerge de novo. The infection is predominantly seen in palate and the dorsum of the tongue of patients who are using inhalational steroids. Other predisposing factors that can cause erythematous candidiasis are smoking and the treatment with broad spectrum antibiotics. Chronic plaque type and nodular candidiasis. The chronic plaque type of oral candidiasis replaces the older term candidal leukoplakia. A white non-scrapable plaque characterizes the typical clinical presentation which may be indistinguishable from oral leukoplakia. Mostly, the differentiating factor between oral leukoplakia and oral candidiasis is that oral candidiasis is scrapable and leukoplakia is a non-scrapable white lesion. But in case of chronic plaque type and chronic nodular candidiasis, the candidal lesion is non-scrapable and the only way to differentiate it from the oral leukoplakia is to take the cytology and the biopsy of the lesion. A positive correlation between oral candidiasis and moderate to severe epithelial dysplasia has been observed, and both the chronic plaque type and nodular type of oral candidiasis have been associated with malignant transformation. There are more number of studies in the literature which suggest that there will be increased risk of malignant transformation whenever leukoplakia lesion is associated with superimposed candidal infection. Denture stomatitis. The most prevalent site for denture stomatitis is the denture bearing palatal mucosa. It is unusual for the mandibular mucosa to be involved. Denture stomatitis is classified into three different types. Type 1 is limited to minor erythematocytes caused by trauma from the denture. They present with punctiform hyperemia. They are very much localized to the point of trauma. Type 2 affects a major part of the denture covered mucosa and they represent diffuse hyperemia. In addition to the features of the type 2, type 3 has a granular mucosa. Type 3 is represented as granular hyperemia. Etiology, trauma. Denture stomatitis is multifactorial in nature, with trauma being a major independent cause. The trauma may originate from ill-fitting or continuously worn dentures or dentures that do not have correct vertical and horizontal arch relations. Nocturnal denture wearing. Nocturnal denture wear plays a role in the etiology of denture stomatitis. Nocturnal and continuous prosthesis wear could reduce the protective effect of saliva, decrease the cleansing effect of the tongue, prevent proper oxygenation of the palatal mucosa, and finally increase local trauma to the mucosa. Denser age. Denser age is thought to be a predisposing factor for development of denser stomatitis, mainly due to the poor possible fitting of the denture, roughness of its surface, impossibility of adequate cleaning, and accumulation of plaque and microbial pathogens. Microorganisms. Candida species are believed to induce the inflammatory response that is characteristic of denture stomatitis. Include the release of yeast antigens, toxins, and irritants from the denture plaque. Also remember the point that microorganisms such as Streptococcus and Staphylococcus can also cause denture stomatitis. Denture lining materials. Denture lining materials, which include tissue conditioners and soft denture liners, are widely used as adjuncts in the prosthodontic treatment and management of traumatized oral mucosa and are most commonly used in association with the mandibular denture. Recently, materials which are available are either silicone elastomers, plasticized higher methacrylate polymers, hydrophilic polymethacrylates, or fluoropolymers. Even though these materials exhibit excellent tissue tolerance, one of the problems is the colonization of Candida species on and within the material. Poor denture hygiene. Lack of denture cleanliness is considered to be one of the factors involved in the etiology of denture stomatitis. Surface texture and permeability of denture-based material. The tissue surface of the dentures usually shows micropits and microporosities. Microorganisms harboring in these areas are difficult to remove mechanically or by chemical cleansing, which leads to candidal overgrowth. Saliva. The role of saliva in the colonization of Candida albicans is still controversial. Some studies have shown that it reduces the adhesion of Candida albicans. In fact, the saliva possesses defensive molecules such as lysosine, lactoferrin, calprotectin, and IgA that decrease the adhesion of Candida to the oral surfaces. Systemic conditions. A variety of systemic conditions may also predispose the individuals to Candida-associated denture stomatitis. Malnutrition. As it occurs in high carbohydrate diets, deficiencies in iron, folate, or vitamin B12, hypoendocrine states such as hypothyroidism, Addison's disease, that is adrenocortical insufficiency, diabetes mellitus, blood disorders such as acute leukemia and agranulocytosis, immune disorders such as HIV infection, thymic aplasia, xerostomia due to irradiation, drug therapy, cytotoxic drug therapy, and Sjogren's syndrome. Through evaluation and correction of oral and denture hygiene measures should be done and nocturnal wearing of dentures should be discouraged. Emphasis should be made on twice weekly soaking of dentures for 15 to 30 minutes in white vinegar, diluted 1:20 0.1% of hydrochloride solution, that is diluted Milton solution or chlorhexidine solution. Denture stomatitis can be effectively managed with antifungal agents and the condition shows complete resolution within 12 to 14 days. 2% miconazole available in gel form can be applied 2 to 3 times daily for 1 to 2 weeks directly to the previously cleaned denture surface. Fluconazole has been widely used because the drug is economic, has lower toxicity and has higher bioavailability. Ketoconazole is also used systemically in a single dose of 200 mg during 14 days. This miconazole 2%, this has antifungal and antibacterial property. Angular cheilitis. Angular cheilitis presents as infected fissures of the commissures of the mouth, often surrounded by erythema. The lesions are frequently co-infected with both Candida albicans and Staphylococcus aureus. Vitamin B12 deficiency, iron deficiencies, and loss of vertical dimensions have been associated with this disorder. 30% of the patients with denture stomatitis also have angular cheilitis, but this infection is only seen in 10% of the denture wearing patients without denture stomatitis. Median rhomboid glossitis. It is clinically characterized as an erythematous lesion in the center of the posterior part of the dorsum of the tongue. This area of erythema results from atrophy of the filiform papillae and the surface may be lobulated. The etiology is not fully understood, but the lesion is frequently showing a mixed bacterial and fungal microflora. Smokers and denture wearers have an increased risk of developing median rhomboid glossitis as well as patients using inhalational steroids. Sometimes a concurrent erythematous lesion may be observed on the palatal mucosa, and when it occurs both in the dorsum of the tongue and palatal mucosa, this is referred to as kissing lesions. This condition was once thought to represent a developmental defect. The embryonic tongue is formed when the lateral processes meet in the midline and fuse over the tuberculum impar. In some cases, the posterior dorsal point of fusion is abnormal, resulting in the development of an area of smooth erythematous mucosa lacking papillae. This area is more susceptible to recurring chronic atrophic candidiasis. Today, however, most authors do not subscribe to the embryogenesis theory. Instead, they believe that median rhomboid glossitis is related to an infection of Candida albicans, which is the most common fungal organism of the oral cavity. These are the candidal fungal hyphae that are seen in median rhomboid glossitis. These are the two lateral lingual swellings, and this is tuberculum impar. It was once thought to be a developmental anomaly, but now it is considered predominantly as a candidal infection. Clinically, median rhomboid glossitis manifests as a well-delineated erythematous area located along the midline posterior dorsal tongue just anterior to the circumvallate papillae. This area represents a zone of atrophic filiform papillae. Its rhomboid shape usually points in an anteroposterior direction. Oral candidiasis associated with HIV. The most common types of oral candidiasis in conjunction with HIV are pseudomembranous candidiasis, erythematous candidiasis, angular cheilitis, and chronic plaque-like candidiasis. As a result of highly active antiretroviral therapy, the prevalence of oral candidiasis has decreased substantially. This is an erythematous candidiasis lesion at the central part of the tongue in an AIDS patient. Hairy leukoplakia can be seen at the right lateral border of the tongue. This is hairy leukoplakia. These are some of the candida isolation techniques. The first method is smear. Smear is done by scraping and smearing the lesional tissue directly onto the slide. The advantage is that it is very simple and quick, but it has low sensitivity. Swab test. It is taken by rubbing cotton tipped swabs over the lesional tissue. It is relatively simple, and the disadvantage is selecting sample sites is critical. Imprint culture. In this, sterile plastic foam pads are dipped into sabron broth and placed on lesion for 60 seconds. Then the pad is pressed on sabron agar plate and incubated. And colony forming units are counted using colony counter. The advantage is that it is sensitive and reliable and can discriminate between infected and carrier states. Disadvantage is that reading above 50 colony forming units per centimeter square can be inaccurate. Selection of sites is difficult if there is no clinical sign. Impression culture. In this, maxillary and mandibular alginate impressions are made, and casting is done in agar fortified with sabron broth, and then incubation is done. This is useful to determine relative distributions of the yeast on the oral surfaces, but it is useful mostly as a research tool, not in clinical practice. Salivary culture. Patient expectorates 2 ml of saliva into sterile container. Vibration is given, and the culture on the sabron agar is done by spiral plating, and then colony counter is used for counting. It is useful as imprint culture. The disadvantage is that considerable chairside time is required, and it is not useful for xerostomics. Also, it cannot identify the site of infection. Oral rinse. In this, subject rinses for 60 seconds with phosphate buffered saline at pH of 7.2 and 0.1 molality and returns it to the original container. And it is concentrated by centrifugation and cultured and countered as in previous methods. This has comparable sensitivity with imprint method. Better results if colony forming units are more than 50 per centimeter square, and again it is a simple method. This is recommended for surveillance only and this cannot identify the site of infection. Smear from the infected area comprising epithelial cells creates opportunities for detection of the yeast. The material is fixed in isopropyl alcohol and air dried before staining with periodic acid shift. The detection of yeast organisms in the form of hyphae or pseudo-hyphae-like structure is usually considered a sign of infection. Also, these structures have also been identified in the normal mucosa. Management of oral candidiasis. Local factors are often easy to identify but sometimes not possible to reduce or eradicate. Antifungal drugs have a primary role in such cases. In smokers, cessation of the habit may result in disappearance of the infection even without antifungal treatment. The most commonly used antifungal drugs belong to the groups of polyenes and azoles. Polyenes such as nystatin and amphotericin B are usually the first choices in the treatment of primary oral candidiasis and are both well tolerated. Polyenes are not absorbed from the gastrointestinal tract and are not associated with the development of resistance. They exert the action through a negative effect on the production of ergosterol, which is critical for yeast cell membrane integrity. Polyenes can also affect the adherence of the fungi to the oral mucosa. When we treat a case of oral candidiasis, elimination or reduction of predisposing factors should always be the first goal for treatment of denture stomatitis as well as other opportunistic infections. This involves improved denture hygiene and a recommendation not to use the denture while sleeping. The denture hygiene is important to remove nutrients, including desquamated epithelial cells, which may serve as a source of nitrogen, which is essential for the growth of the yeast. Denture cleaning also disturbs the maturity of a microbial environment established under the denture. As porosities in the denture can harbor microorganisms which may not be removed by physical cleansing, the denture should be stored in antimicrobial solutions during the night. Different solutions including alkaline peroxides, alkaline hypochlorites, acids, disinfectants and enzymes have been suggested. The latter seems to be the most effective against candidal strains. Chlorhexidine may also be used, but it can discolor the denture and also counteracts the effect of nystatin. Type 3 denture stomatitis may be treated with surgical excision in an attempt to eradicate microorganisms present in the deeper fissures of the granular tissue. If this is not sufficient, continuous treatment with topical antifungal drugs should be considered. Topical treatment with azoles such as miconazole is the treatment of choice for angular cheilitis, often infected with both Staphylococcus aureus and Candidal strains. This drug has a biostatic effect on Staphylococcus aureus in addition to the fungistatic effect. Ritapamulin can also be used as a complement to the antifungal drugs. If angular cheilitis comprises an erythema surrounding the fissure, a mild steroid ointment may be required to suppress the inflammation. Systemic azoles may be used for deeply seated primary candidiasis such as chronic hyperplastic candidiasis, denture stomatitis and median rhomboid glossitis with a granular appearance, and for therapy-resistant infections mostly related to compliance failure. Development of resistance is particularly compelling for fluconazole in individuals with HIV disease. In such cases, ketoconazole and itraconazole have been recommended as alternatives. Prognosis of oral candidiasis is good when predisposing factors associated with the infection are reduced or eliminated. Persistent chronic plaque type and nodular candidiasis have been suggested to be associated with an increased risk for malignant transformation as we discussed earlier, compared with the leukoplakia not infected by the candidal strains. Here are some topical prescription medications for the treatment of candidiasis. Clotrimazole and miconazole or azole group of drugs, and nystatin is a polyene. Clotrimazole is available as 10 mg trough, and 10 mg trough is dissolved in mouth 5 times daily for 7 to 14 days. And this clotrimazole trough should be used at least 48 hours after resolution. The reason is fungal infections often involve spores, which can remain dormant even after the initial symptoms subside. So, it should be used at least for 48 hours after resolution of the symptoms. There is no contraindication for clotrimazole, and precaution to be taken in patients with azole hypersensitivity. Common side effects include abdominal pain, nausea, and diarrhea. Rare complications include oral pruritus and elevated liver enzymes. Important drug interaction is tacrolimus. Miconazole, it is available as 50 mg tablet. This should be applied as one tablet to the upper gum above the incisor 4 times daily for 14 days. And it is contraindicated in patients with milk protein hypersensitivity. Precautions to be taken in patients with azole hypersensitivity and hepatic impairment. Common side effects include gingival pruritus, burning or pain, toothache, nausea, vomiting, diarrhea, and dysgeusia. Rare complications include elevated hepatic enzymes. Important drug interactions are cisapride, ranolazine, and silostazole. Nystatin, it is a polyene and it is available as 1 lakh unit per ml oral suspension. 4 to 6 ml of the nystatin oral suspension should be swished around the mouth for 1 minute 4 times daily for 7 to 14 days, and also it should be used for at least 48 hours after the resolution of the symptoms and the lesion. There are no contraindications, and precautions are to be taken in patients with diabetes mellitus since it contains sucrose, and also in patients with paraben hypersensitivity. Common side effect is stomach upset. We will discuss in detail about some of the topical and systemic antifungal agents. Amphotericin B, it is available as 10 mg lozenge. It is to be slowly dissolved in mouth 3 to 4 times daily after meals for 2 weeks minimum. And it's also available as oral suspension of 100 mg per ml. It is to be placed in the mouth after food and retained near the lesions 4 times daily for 2 weeks. It has negligible absorption from gastrointestinal tract. When given IV for deep mycosis, it may cause thrombophlebitis, anorexia, nausea, vomiting, fever, headache, weight loss, anemia, hypokalemia, nephrotoxicity, and hypotension and arrhythmias. Nystatin, it is available as cream and it's to be applied to the affected site 3 to 4 times daily. It is available as 1 lakh unit pastille. Pastille is to be dissolved slowly after meals for 4 times daily for usually 7 days. And it's also available as 1 lakh unit oral suspension. It is to be applied after meals 4 times daily, usually for 7 days. Similarly, nystatin has negligible absorption from the GIT as that of amphotericin B, and it causes nausea and vomiting in high doses. One of the commonly used topical antifungal agent in practice for oral candidiasis is candid mouth paint, which is 1% clotrimazole. It is available as solution, which is to be applied 5 ml 3 to 4 times daily for minimum of 2 weeks. And it is also available as cream, which is to be applied to the affected area 2 to 3 times daily for 3 to 4 weeks. It has mild local effects such as burning sensation, and also it has anti-staphylococcal activity. Miconazole is available as 2% oral gel and cream. Oral gel is to be applied to the affected area 2 to 3 times daily, and cream to be applied twice per day, and this is to be continued for 10 to 14 days after the lesion heals in order to eradicate the spore forms. And mild local reactions are the adverse effects, and also it interacts with the anticoagulants such as warfarin and terfenadine, cisapride, and estimazole. This is to be avoided in pregnant women and liver disease patients. Ketoconazole. Ketoconazole is available in tablet form. 200 to 400 mg is the dose usually used. 200 to 400 mg tablets are taken once or twice daily with food for 2 weeks for maximum compliance. And the adverse effects are nausea, vomiting, rashes, pruritus, liver damage. And also this interacts with anticoagulants and are contraindicated in liver disease patients and pregnant women. Fluconazole is available as 50 to 100 mg capsule and it is to be taken once daily for 2 to 3 weeks. It interacts with anticoagulants and contraindicated in pregnancy, liver and renal disease. This may cause nausea, vomiting, headache, rash and liver dysfunction. Itraconazole. Itraconazole is available as 100 mg capsule and it is to be taken daily immediately after meals for 2 weeks. Itraconazole is also available as solution, which is available in the trade name IT Max solution, which is to be swished and swallowed 5 ml twice daily. This interacts with terfenadine cisapride. This is contraindicated in pregnancy and liver disease. This may cause nausea, neuropathy, and rash. One of the common side effects of the systemic antifungal agents are the interaction with the anticoagulants and also hepatic dysfunction. Next, we will discuss in detail about the deep fungal infections. Blastomycosis. Blastomyces dermatitis is the causative organism for blastomycosis, and it is a dimorphic organism that can grow either as yeast form or as mycelial form. It is a normal inhabitant of soil, and agricultural and construction workers are at highest risk of infection, particularly those working in the Mississippi and Ohio River valleys and around the Great Lakes and the St. Lawrence Seaway. This geographic distribution has led to the designation by some authors as North American blastomycosis. However, infection by the same organism has been found in Mexico and Central and South America. Immunosuppressed patients such as HIV patients and solid organ transplant patients are at particular risk for developing blastomycosis. Also, patients receiving tumor necrosis factor antagonists for autoimmune diseases are at an increased risk. Infection with blastomyces begins in a majority of cases by inhalation. This causes a primary pulmonary infection. The infection commonly follows a chronic course, beginning with mild symptoms such as malaise, low-grade fever, and mild cough. If the infection goes untreated, the signs and symptoms may mimic TB and include dyspnea, weight loss, and production of blood-tinged sputum. Some patients develop acute respiratory distress syndrome with a mortality rate of 50 to 89%. Infection of the skin, mucosa, and bone may also occur, resulting from spread of the organisms from the pulmonary lesions through the lymphatic system. So the primary infection is by inhalation and then it affects the lungs and then the secondary infection reaches the other organs. The skin lesions, usually on the exposed surfaces, start as subcutaneous nodules, slowly progressing to well-circumscribed indurated ulcers. Blastomycosis is diagnosed using real-time PCR, antibody identification through enzyme immunoassay, biopsy, and culture on Sabron agar. The organism is often identified in sputum or biopsy specimens characterized by the presence of granulomas with unipolar budding yeasts. Itraconazole therapy is used to manage mild cases of blastomycosis. More advanced cases are treated with amphotericin B. So, deep fungal infection is something which develops through the systemic infection. Oral or facial considerations. Oral lesions are rarely the primary site of infection, as we discussed earlier. When oral lesions have been reported as a first sign of blastomycosis, they have occurred in patients with mild pulmonary symptoms that have been overlooked by patients or physician. Most cases of oral involvement demonstrate concomitant pulmonary lesions on the chest radiographs. The most common appearance of the oral lesions of blastomycosis is a non-specific painless ulcer with indurated borders and verrucous mucosal hyperplasia, often mistaken for squamous cell carcinoma. Here we can see the irregular ulceration of the tongue, which represents blastomycosis, and granular exophytic and indurated mass on the buccal mucosa. The lesion appears like carcinomatous lesion, but it is a deep fungal infection. Treatment of blastomycosis. Amphotericin B deoxycholate has a long track record of clinical success with high cure rates. Itraconazole is the first line agent for the treatment of mild to moderate cases. Amphotericin B 1 mg per kg per day is the recommended dose. Oral itraconazole is given 200 mg 3 times daily for 3 days. Oral fluconazole is given 800 mg daily. Voriconazole is given in advanced cases which has developed resistance to other antifungal agents. It is given in the dose of 200 to 400 mg twice daily. The next deep fungal infection is histoplasmosis. It is caused by Histoplasma capsulatum and it is also called as Darling's disease or Ohio Valley fever. Histoplasma capsulatum is a dimorphic fungus with both yeast and mycelial forms that grows in yeast form in infected tissue. Infection results from inhaling dust contaminated with droppings, particularly from infected birds or bats. An African form of this infection is caused by a larger yeast, Histoplasma dubosei, which is considered as a variant of Histoplasma capsulatum. Histoplasmosis is the most common systemic fungal infection in the United States and presents primarily as pulmonary disease. In endemic areas such as Mississippi and Ohio River valleys, serological evidence of previous infection may be found in 75% to 85% of the population. Outbreaks of occupationally acquired histoplasmosis continue to be reported among agricultural workers and laborers in the endemic areas. Particularly at risk are individuals working with aerosolized topsoil or dust with bat or bird droppings. In most cases, particularly in otherwise normal children, primary infection is mild, manifesting as a self-limiting pulmonary disease that heals to leave fibrosis and calcification similar to tuberculosis infection. In a small percentage of cases, progressive disease results in cavitation of the lung and dissemination of the organism to the liver, spleen, adrenal glands, and meninges. Patients with the disseminated form of the disease may develop anemia and leukopenia secondary to bone marrow involvement. Immunosuppressed or myelosuppressed patients are more likely to develop the severe disseminated form of the disease. A rapid diagnosis may be made with the use of the smear of the lesion stained with methenamine silver or biopsy of the lesion stained with periodic acid chip or methenamine silver, which will reveal the presence of the fungi with granulomas. Culture should be performed on a portion of the tissue removed during the biopsy. Immunocompromised patients with disseminated histoplasmosis are generally treated with amphotericin B and are triazole such as itraconazole. Occasionally, patients have also been treated with voriconazole and posaconazole in case of resistance to other antifungal agents. Oral or facial considerations of histoplasmosis. Oral involvement is usually secondary to pulmonary involvement and occurs in a significant percentage of patients with disseminated histoplasmosis. Most cases of oral histoplasmosis reported during the past 2 decades have been detected in HIV individuals who live in or have visited endemic areas and may represent primary oral involvement or part of disseminated infection. Oral mucosal lesions begin as an erythema that becomes a papule and eventually forms a painful granulomatous appearing ulcers, often with an indurated border on the gingiva, palate, or tongue. Some lesions are fungating. The cervical lymph nodes are often enlarged and firm. The clinical appearance of the lesion as well as the accompanying lymphadenopathy often resembles that of squamous cell carcinoma and other chronic fungal infections or lymphoma. Here we can see an ulcerated granular lesion in the maxillary buccal vestibule which resembles oral carcinoma. Treatment of histoplasmosis. Histoplasmosis is usually a self-limited process, generally warrants no specific treatment other than supportive care with analgesics and antipyretics. In case of chronic histoplasmosis, intravenous amphotericin B and itraconazole can be used. In case of disseminated histoplasmosis, amphotericin B, itraconazole or ketoconazole can be used. Pulmonary histoplasmosis usually resolves spontaneously, while severe forms of the disease are usually treated by amphotericin B. Prophylaxis with itraconazole of 200 mg daily is recommended in patients with HIV infection and with CD4 counts less than or equal to 150 cells per millimeter cube. Liposomal amphotericin B 5 mg per kg daily for a total of 175 mg per kg is given over 4 to 6 weeks. Paracoccidiomycosis. Paracoccidiomycosis is caused by the organism Paracoccidiomycosis brasiliensis. It is also called as South American blastomycosis. It is an endemic disease from Mexico through Central America down to Argentina in South America. The Nike for the organism is thought to be soil or wood, and inhalation is the root of infection. Most patients are asymptomatic after the initial infection, but the organism can be dormant within the lymph nodes for many years and then reactivate when the patient experiences some types of immunosuppression. The disease affects primarily men, 15:1 ratio for men to women, and older than 30 years. When activated, the infection involves primarily the oral mucosa, lungs, and skin. Other potential sites of involvement are gastrointestinal tract, liver, bones, central nervous system, and the male genitourinary tract. In severe cases, signs and symptoms may mimic those of TB and include fever, weight loss, and productive cough with bloody sputum. Here we can see the oral involvement. It commonly affects the gingiva and the palatal mucosa, and you can see there is a granular appearance of the surface with erythema and ulceration. The diagnosis is accomplished by direct examination of the sputum, biopsy material from ulcers, or pus draining from the lymph nodes. Establishing the diagnosis may be difficult as the organism occurs in the mold form and or the yeast form. It is necessary to observe the yeast form, and this can be seen in 10% potassium hydroxide preparation. The specimen is then isolated in the culture. Paracoccidiomycosis is treated with azole antifungals, with itraconazole being the preferred one due to lower relapse rates. Amphotericin B may be given with azoles, and maintenance therapy for up to 5 years is often necessary. Oral mucosal lesions are a predominant feature of paracoccidiomycosis and present as ulcers, and oral complaints are often the presenting symptoms of these patients. Lesions of the gingival mucosa are most common, followed by the palate and lip. The lesions are frequently painful. Ulcerative lesions with crusting also occur on the facial skin and may infiltrate subcutaneously. Here we can see oral involvement of paracoccidiomycosis. Here the alveolar mucosa is granular, erythematous and ulcerated. This represents the infection by Paracoccidioides brasiliensis. This is one of the fungal infection which primarily affects the oral site. Aspergillosis. Aspergillosis is caused by Aspergillus fungi. Organisms of the fungal genus Aspergillus cause multiple infections including pulmonary infections, invasive aspergillosis, and allergic bronchopulmonary reactions. It is widely distributed in the environment and is transmitted by airborne live spores. High environment load is associated with sick building syndrome and contaminated AC system. Commonly found in soil, on plants, in decaying organic matter, and in dust form from houses and building materials, Aspergillus species are ubiquitous in the environment, and colonization of the respiratory tract is common in humans. The two most common infecting organisms are Aspergillus fumigatus and Aspergillus flavus. In addition to the lungs, invasive aspergillosis can involve the central nervous system, bones, eye, heart, and kidneys. Aspergillus infections are diagnosed using direct examination of clinical specimens on 10% KOH and then isolated with specific culture techniques. Invasive aspergillosis has a high mortality rate, but early diagnosis improves the prognosis. Assay for galactomannan antigen, an exoantigen of aspergillus in the blood, is often used as an effective screen for early detection in the patients at risk. In oral cavity, the common site of involvement of aspergillosis infection includes tongue, soft and hard palate, occasionally pulp and periodontal tissues. The involvement of maxillary sinus can sometimes result in an extension of the infection to adjacent structures such as palate, and when they involve palate, they form painful ulceration surrounded by necrotic black tissues. Here we can see maxillary sinus infection of aspergillosis has caused extension into the palate, and there is a ulcerated area with black tissue on the surface. Treatment of invasive aspergillosis is accomplished with several systemic antifungal medications, including voriconazole, amphotericin B, itraconazole, posaconazole, caspofungin, and micafungin. Antifungal prophylaxis may be employed in certain high-risk groups such as those who have received organ transplantation. Oral colonization with Aspergillus species is common, although oral infections are rare. In contrast, allergic bronchopulmonary aspergillosis of the sinuses is fairly common. Patients presenting with lingering chronic sinusitis of the maxillary sinuses that is not responsive to standard antibacterial medication can be considered to have Aspergillus infection. Standard medical therapy consists of corticosteroids and itraconazole, with some cases requiring surgery to clear the condition. Here we can see a purplish swelling of the hard palate after induction chemotherapy for leukoplakia. It is an Aspergillus infection. This is a panoramic radiograph of a case of maxillary sinus aspergillus infection. This shows a radiopaque mass in the left maxillary sinus. Axial section of cone beam computed tomographic image of the same patient shows an iron-like opacity in the central area of the left maxillary sinus. And the CBCT image on the coronal plane shows the lesion in the maxillary sinus and the sinusitis caused by aspergilloma. Here there is a soft tissue growth in the sinus. This is caused by soft tissue shadow. Lab investigation. Specimens such as sputum, bone marrow aspirate, and biopsy are to be examined. Direct microscopy shows branching septae hyphae. Culture microscopy shows radiating chains of spores. Serology in allergic condition, high levels of specific immunoglobulin E and galactomannan in the invasive aspergillosis will be noted. Treatment involves debridement of the ulcerative lesions, and in case of invasive aspergillosis, amphotericin B is to be given, and allergic conditions, steroids and antifungal are the commonly administered treatment. Cryptococcosis. Cryptococcosis is caused by Cryptococcus neoformans. Cryptococcosis is a worldwide infection that develops after the fungal spores are inhaled from soil contaminated from bird droppings, primarily with two species, Cryptococcus neoformans and Cryptococcus gatei. The infection is common in patients with a compromised immune system such as with HIV, steroid exposure, transplantation, diabetes and pregnancy, but otherwise healthy people may become also infected. The patient presents with symptoms of pneumonia including cough, fever, chest pain and weight loss. In others, the patient remains asymptomatic but develops a latent infection that remains dormant. The most serious infection involves CNS and causes meningoencephalitis. Symptoms include fever, headache, lethargy, and mental changes and can lead to permanent neurologic damage. Cryptococcosis is diagnosed by microscopic examination and or culture of the tissue or body fluids. A cryptococcal antigen test may provide a rapid diagnosis when done on blood or cerebrospinal fluid. Severe cryptococcal infections, particularly those of the central nervous system, are treated with amphotericin B with flucytosine. Less severe infections are treated with fluconazole or itraconazole. Treatment requires long courses of medication of at least 6 months or longer. Maintenance therapy may be permanent in patients with cryptococcal meningoencephalitis. Oral lesions of cryptococcosis may occur in patients with disseminated disease and immunosuppression. They have been described as ulcers or tumor-like nodules occurring on the gingiva and tongue. Here we can see there is a tumor-like mass in the maxillary and mandibular gingival region, which is a characteristic feature of cryptococcal infection. The next systemic fungal infection is mucormycosis. Mucormycosis is caused by fungi mucorale, and we all are aware of mucormycosis, especially after COVID infection. It was one of the post-COVID complication. The term mucormycosis describes an infection that is caused by the class of fungi known as the mucorales, with the most common infecting organism being Rhizopus adhesius. The order is mucorales, from which is derived the terminology mucormycosis. And Rhizopus, mucor, and Listhemia, formerly known as Absidia, can all cause mucormycosis. The term zygomycosis has also been used for these infections, but currently mucormycosis is the preferred term. These organisms are typically found in the soil and decaying organic matter. These fungi are non-pathogenic for healthy individuals and are opportunistic pathogens. They are regularly cultured from the human nose, throat, and oral cavity of the healthy asymptomatic individuals. The two most common forms of mucormycosis are pulmonary or sinus and cutaneous. In the pulmonary or sinus mucormycosis, spores are inhaled from the environment. For the cutaneous disease, the spores enter traumatic wounds to the skin, such as those occurring in impact injuries contacting the ground. Pathogenesis, spread and complications of mucormycosis. Mucormycosis spores can be either inhaled or ingested. Then it reaches the nasal or oral mucosa of the immunocompromised patients. In immunocompromised patients, phagocytic response will be either diminished or absent. So this leads to germination of aseptate hyphae. And then this aseptate hyphae cause invasion of the vascular channels, and they cause stasis and occlusion of the vessels, leading to thrombosis. Then thrombosis leads to ischemic necrosis. Also, in case of poorly controlled hyperglycemics, it can cause microangiopathy and atherosclerosis, which leads to ischemic necrosis. As well, poorly controlled hyperglycemics will have impaired or delayed wound healing. So, as like immunocompromised patients, the opportunistic fungal infections are common, which leads to non-healing extraction socket and gives the space for germination of the aseptate hyphae. The final result is ischemic necrosis through this phase. Then fungal osteomyelitis of the maxillary antrum occurs. Infection spreads through the ethmoidal artery via the spinopalatine artery, and then it reaches the apex of the orbit. Then from the apex of the orbit, the infection reaches the lateral wall of the cavernous sinus and to internal carotid artery. When it reaches internal carotid artery, cerebral ischemia and death happens. Mucormycosis is characterized by arterial invasion and a fulminant course, frequently resulting in death. The hallmark of infection is the formation of emboli with resulting necrosis of involved tissue. Mucormycosis may present as pulmonary, sinus, rhinocerebral, skin, or disseminated infection. Infection occurs in patients with decreased host resistance, such as those with poorly controlled diabetes, hematologic malignancies, post-solid organ transplantation, post-hematopoietic cell transplantation, patients with severe trauma or burns, and patients on deferoxamine therapy. Early diagnosis is essential for improved survival and reduced morbidity from extension of disease and dissemination. Negative cultures do not rule out mucormycosis because the fungus is frequently difficult to culture. Instead, a biopsy for culture and direct examination must be performed. The histopathology shows necrosis and non-septate hyphae, which are the best demonstrated by periodic acid stain or methenamine silver stain. Necrosis and occlusion of vessels are also frequently present. Newer techniques of identification include the use of PCR. First-line therapy for mucormycosis consists of surgical debridement and amphotericin B, whereas second-line treatment includes other antifungal chemotherapeutic agents such as posaconazole and caspofungin. The mortality rate is 50% to 100% in spite of therapy, compared with 35 to 45% for aspergillosis, and an increasing number of cases has been noted in immunocompetent patients. The rhinomaxillary form of the disease, a variant of the rhinocerebral form, begins with the inhalation of the fungus by susceptible individual. The fungus invades the blood vessels and causes damage secondary to thrombosis and ischemia. The fungus may spread from the oral and nasal region to the brain, causing death in high percentage of cases. The most common symptoms of the rhinomaxillary form includes proptosis, loss of vision, nasal discharge, sinusitis, and palatal necrosis. The most common oral sign of mucormycosis is ulceration of the palate, which results from necrosis due to invasion of the palatal vessel. The lesion is characteristically large and deep and may lead to exposure of underlying bone. Ulcers from mucormycosis have also been reported on the gingiva, lip, and alveolar ridge. The initial manifestation of the disease may be confused with pain from an odontogenic infection or conventional bacterial maxillary sinusitis. More advanced disease with ulcer and palatal perforation may suggest an anti-neutrophil cytoplasmic antibody associated vasculitis, that is vaginous granulomatosis. Here we can see an extensive black necrotic lesion of the palate, which represents zygomycotic infection that extend from the maxillary sinus in a patient with poorly controlled type 1 diabetes mellitus. Radiographically, opacification of the sinuses may be observed in conjunction with patchy effacement of the bony walls of the sinuses. Such a picture may be difficult to distinguish from that of a malignancy affecting the sinus area. This is a computed tomographic scan which demonstrates opacification of the left maxillary sinus. Here we can see there is an opacification. Treatment for mucormycosis, liposomal amphotericin B 5 mg per kg per day or isavuconazole, especially in patients for whom amphotericin B is inappropriate. The dose for isavuconazole, loading dose of 372 mg, 8 hourly for 6 doses either as IV or oral route. The regimen is to be continued for at least 3 weeks. Posaconazole tablets 300 mg per day. In one retrospective case series, 32 patients with hematological malignancies or aplastic anemia and mucormycosis unresponsive to prior monotherapy, mainly with liposomal amphotericin B, were treated with a combination of Pauline and posaconazole. After 3 months of treatment, 18 patients, that is 56% of the patients, had clinical improvement, and 9 patients, that is 28% of the patients, did not respond or died from progression of the disease. Sporotrichosis. The etiological agent is Sporothrix schenckii. Oral manifestations include primary oral sporotrichosis occurs rarely but occurs secondary to dissemination from the diseases of the lung and skin. Oral lesions manifest initially as erythematous ulcerative and suppurative lesions and eventually become granulomatous, vegetative, or papillomatous. Pain is the basic feature of the oral lesions and lymph nodes become hard. It heals without scarring. Here we can see an ulcerated lesion of the upper lip which has suppurative lesion and it is erythematous. Later this kind of lesion will become granuloma or vegetative or papillomatous lesion. Coccidioidomycosis. It is also called as San Joaquin Valley fever or valley fever. Etiological agent is Coccidioides immitis. Oral manifestations. Oral lesions are uncommon and are clinically described as ulcerated granulomatous nodules that heal by hyalinization and scar. Here we can see in the lateral anterior border of the tongue, there is a large ulcerated lesion with indurated borders. Later, when the ulceration heals, there will be scar formation. Geotrichosis, the etiological agent is Geotrichum candidum. Oral manifestations, the oral lesions of geotrichosis are similar clinically to pseudomembranous candidiasis, and the differentiation can be done only by histopathological examination and culture of the organism. Besides the pseudomembranous form, other clinical presentations of oral geotrichosis have been reported, such as villous hyperplastic and ulcerative forms. This is a pseudomembranous geotrichosis, which appears similar to clinical presentation of candidiasis. Penicilliosis, etiological agent is Penicillium marniae. Oral manifestations, oral lesions usually appear as shiny papules, erosions, or as shallow ulcers covered with whitish yellow necrotic slough and are found on the palate, gingiva, labial mucosa, tongue, and oropharynx. Here we can see an oral lesion in the maxillary gingiva and in the vestibule, maxillary labial vestibule, and as well as in the upper labial mucosa. There is a shallow ulceration covered with white pseudomembrane. Diagnosis is usually confirmed by histology and culture. In the presence of lymphadenopathy, fine needle aspiration has proven to be a useful diagnostic tool. The dosage and duration of the treatment among HIV infected patients were intravenous amphotericin B deoxycholate 0.6 to 1 mg per kg per day for 2 weeks, followed by oral itraconazole 400 mg per day for 8 to 10 weeks. Itraconazole 200 mg per day for secondary prophylaxis is to be given. Rhinosporidiosis, etiological agent is Rhinosporidium seaberi. Oral manifestations, the oral lesions show a mucoid discharge and appear as soft red polypoid growths. Nasal mucosa is the most commonly affected site. Lesion appear as small verrucae or warts which ultimately become pedunculated. Here we can see a polypoid erythematous mass behind the tonsillar pillar which is pedunculated. These masses bleed very easily and soft palate is the most frequently affected site. So students, here we come to the end of fungal infections of the oral cavity. Thank you for listening.